There have been a number of changes in Korea's response measures to Omicron as authorities hope its peak will ultimately lead to a visible transition into a new normal. For more, I have Professor David Kwak from Soonchunang University. Professor Kwak, welcome back.
Good afternoon, Sunny.
I also have Dr. Kim Seung-taek at Institute Pasteur Korea live on the line. Dr. Kim, it's good to see you.
Good afternoon.
Professor Kwak, we'll start here in the studio. Authorities believe Korea's Omicron wave will peak within the next week or two and then start to decline. Do you share this outlook?
Well, now I have to. I have been saying for the past 3-4 weeks that there were other projections made by other associations that it was also likely to happen on 6th of March. We already passed few days of that, and we're still seeing the graph steeply go up. If the correct projection was made by the government, and they said that we will be likely to see the peak in the mid of March, which falls hopefully within this week and next week, and hopefully we'll go over the peak in that period, and hopefully also we'll see a steep decline after that.
Right. And Dr. Kim, what would you say are some of the most concerning aspects, that is, of our current COVID-19 situation?
Well, currently, as just earlier mentioned, we are actually just seeing over the 300,000 of total number of COVID-19 infection, and typically we observe the number of severe patient numbers is like after at least a week after confirming the COVID-19. So then maybe just the most concern is that whether we are the number of severe COVID-19 patients is increases. Well, as of now, the number is just a little over 1,000. But I'm just kind of worried that if our healthcare system can deal with the maybe just potentially some more increasing number of severe COVID-19 patients. Yeah, that's it.
Dr. Kim, starting on this Monday, positive rapid antigen test results will be accepted as formal diagnosis of COVID-19, as reported by my colleague Sung-woo earlier on. What are your thoughts on this shift in testing strategy?
Well, I think this is just basically there are just a way to number too many the PCR tests are just being done right now, and then subsequently there's a kind of a delayed notification of the whether infection is just on or off is possible or not, and then subsequently the speed of the prescription, and then by doing this fast the diagnosis in the more the expedited manner, this will actually just enable some more faster the prescription. But we have to just keep in mind that this is only for the people with over 60 years of age, and then for the 40s and then the 50s or some underlying medical condition, they still need some PCR test results before just a prescription. And then this fast test and then the fast prescription is very important, especially for some oral drugs that we are actually using right now, because this is an antiviral drug, and considering their mechanism of action, the fast the prescription and the use of this drug is very critical to obtain some best performance of these oral drugs.
Right. And in the meantime then, Professor Kwak, what do you propose then to address the relative inaccuracy of rapid antigen tests as compared to their PCR counterparts?
Right. So let me begin by distinguishing the accuracy of the rapid antigen test versus the PCR test. PCR test, as originally tested to confirm the diagnosis of COVID-19, is actually an amplification of any sort of genetic material within the human body of COVID-19. So it amplifies even a dissected particle of SARS-CoV-2 virus, meaning if there was to be remaining particle long time after an infection, it'll show up in the PCR test. So we have set roughly at around 31, in between 31 to 35 of cyclic value. If it shows up in the RT-PCR, we would consider that to be positive of COVID-19 infection, meaning something that's less of a 31 cyclic value would be considered to be a current infection of COVID-19. Anything beyond that is clinically suspected to be either remaining particle from past infection, or it could be something of the person's being exposed to COVID-19 and not actually being infected. Of course, being tested negative from RT-PCR would definitely mean that the person has not COVID-19, because there is not even a dissected particle remaining from the original virus strain. Now, going to rapid antigen test. Antigen is a molecule that shows up in human body once the virus infects human cells. So it starts testing positive not immediately after infection, but after a certain period of time. Usually we suspect that to be either 1 to 3 days, but antigen starts to go up during the infection and it slowly goes back down when the infection is over. So it's probably the second accurate diagnostic tool for diagnosis of COVID-19. Now, that being said, the paradigm of diagnosing patients with COVID-19 has changed in Korea since the beginning of pandemic to the current time. Because in the beginning, or until the Delta variant, we needed to have traced back all possible contacts of COVID-19 to make sure that it no longer passes on to anyone else. So we needed the strictest tool possible to pick out everyone who's having COVID-19 infection, make sure they don't go around and transmit to others. Now, as we're seeing more than 300,000 of daily confirmation cases. It's inevitable that we are not able to prevent any further transmission, even if we try to. So now the paradigm has shifted to where, clinically speaking, we need to focus on treating those patients who may be more vulnerable to become more sick, rather than preventing transmission completely. In that regard, RT-PCR has less of the value than picking up who might be going through infection itself currently. So it's no longer, quote unquote, required for a person to receive RT-PCR, but rather we should use a method that picks diagnosis much faster than the others, and also which is more accessible. Obviously, that will be rapid antigen in the case. So that because of that, even though rapid antigen test tends to be less accurate than RT-PCR, clinically speaking, rapid antigen test is also currently needed. Now, let me just add one more thing quickly, though. Rapid antigen test has a very strong sensitivity rate, as opposed to very weak specificity rate, meaning it has a tendency to show great numbers of false negative. But once it tests positive, it is very, very likely the person is actually positive. So we need to make sure it is used righteously for its own purpose. It is used to pick up a person who's positive, but it should not be used to make sure the person is negative, because there will be so many cases of false negatives. Let's just make sure of that.
Right. And Dr. Kim, what can you tell us about the accuracy of PCR tests based on throat swabs that have been approved for mobile testing units over at schools?
Well, I think this starts from the actually complaining of the school-aged children, and because of the very frequent just the testing, especially just the collecting the specimen from the nasal cavity. They actually just complain about the discomfort by this procedure. So then some government actually just chose maybe just a throat swab instead of the nasal cavity swab. And in the beginning, the swabbing, collecting the samples actually were just three different positions. I mean, in China originally, they actually collect the specimens from the actually nasal cavity and then throat, and also sometimes a nasal anal swab. So, but the last one is actually very discomforting, and then probably most people wouldn't like it. So the nasal swab and then the throat swab is kind of just a common standard. And I think for the PCR test, well, the actually viral replication, actually, it's not really just uniform on the in terms of just the infection course. Well, depending on also depending on the variant of this SARS-CoV-2, sometimes the virus replication starts from some other parts of the respiratory tract, and it's kind of just a viral load is actually changes over the some infection courses. So many places, if we pick just many area from our respiratory tract, the chances are we are actually just testing more sensitivity, but then I think considering all the complaining about some discomfort, I think especially for the PCR test, I think throat swab maybe just sensitive enough. And for the some rapid antigen test, and there's also some debate whether like those are nasal swab or just the throat swab is just enough. And then, well, I think for the even just the rapid antigen test. I think one of the funny thing is that several teenagers actually tested some rapid antigen test with many different kinds of just the liquids, including some beverages. And then, well, interestingly, just some lemon juice, sort of like some acidic just beverages, and also sodas actually make this test positive. And then, so I think one of the things that we can actually recommend is that before just taking just the samples, maybe just blowing nose and then just rinse just the mouth. Maybe just also one of the recommendations we can actually suggest.
Right, I see. And meanwhile, Professor Kwak, mild COVID-19 patients can now be treated within regular hospital wards. Having said that, how is your hospital responding to this change in treatment protocol?
Right. So the formal guideline that was made by the government recently was for the bigger hospitals to start allowing patients from past COVID-19 infection, once they become milder in symptoms from their severe course of it, to be allowed to stay non-COVID-19 isolation booths. So a couple of much bigger hospitals, such as Seoul National University Hospital and Asan Hospital, has started actually allowing patients recovering from COVID-19, showing only very mild cases, to be allowed to stay within a regular admission ward. But they are actually still having them being admitted in individual rooms instead of the regular 6 people, 8 people admission wards that we would ordinarily see in the TV. So it's not exactly the case where just COVID-19 patients started just going into a regular admission room. It is the same in our hospital as well. So for the patient who has gone through a severe course of COVID-19 but has recovered and showing very mild symptoms only, but also showing possibly remaining particles through RT-PCR, are currently allowed to stay in regular individual rooms, not just completely in the negative pressure isolation booths. So that is being conducted at our hospital as well. I think government, because of lack of resources that we're facing nationally, the government wants to utilize as much as possible of any of the resources that we currently have. So they want to allow actual COVID-19 patients to be treated at regular clinics. The biggest concern that I have about that is still the transmission rate. We still have those people who would be vulnerable still be visiting hospitals that have not been completely immunized against COVID-19 to possibly be exposed to the viral particle from the hospital if they were to come close to a transmissible person per se. So I don't think allowing all clinics to suddenly start treating for COVID-19 patients is the best idea currently, but we need something in the middle, in between the steps, where we still need to take care of COVID-19 patients recovering, not completely exposed to non-immunized people. So we need to find maybe possibly the alternative that I'm thinking of is designating other bigger sized local hospitals to mainly focus on COVID-19 patients only, even those who recovered from it, but isolating or differentiating those who have not been immunized COVID-19 to actually still go to non-COVID-19 hospitals yet.
Right, and talking about protecting people from COVID-19, let's talk about COVID-19 vaccination for children here in the country, Professor Kwak. Those aged 5 to 11 will now be able to receive their vaccines starting late this month with the Pfizer vaccine, of course. What are your thoughts on this inoculation initiative?
Well, you already see the smile on my face. I have been requesting and demanding on many programs that the government should start allowing these children between ages of 5 to 11 to receive the vaccine. I still don't think it should be a mandate because the parents or the patients themselves still needs to be free to choose for themselves to receive the vaccine. But as a parent of 3 children, I do plan on getting my children vaccinated because as we have seen from the reports, there are rare but still happening cases of children going through severe courses of COVID-19, let alone for even younger children who has a underdeveloped respiratory tract. They're also prone to have a condition called croup, which is a constrictions in the airways. They have more difficulty breathing and whatnot. That is not entirely primarily due to COVID-19, but it's a condition that can stem from multiple different types of viruses. So, in essence, COVID-19 vaccine still would benefit these children between those ages very, very much. And I very welcome the decision by the government to start allowing these children as well.
Right. And moving forward, Dr. Kim, what can you tell us about the so-called Delta Crohn that my colleague Soa mentioned earlier on, which has been making COVID-19 headlines in recent days?
Right. And also, as you just guys discussed, this is not just the first time that you're actually talking about Delta Crohn. This was also just suggested or just reported just last January. And then in that time, actually, most of the experts say that, well, maybe this is just due to the some laboratory contamination issues. And then probably no one actually took this very seriously. But now, just some several countries, this sort of just the Delta Crohn, seems to just appear. And then, also some people said instead of Delta Crohn, they say Delta Omicron and whatever names. And that as the name means that but basically based on the some genetic just sequencing the data analysis, the virus seems to have both just genetic information from the Omicron and then the Delta. And then if we look at the more just in detail the some genetic just the makeup of these viruses, the spike gene seems to come from the Omicron variant, but the rest of the viral gene actually came from the Delta variant. What that means is that, well, obviously we have actually just wait what the variant means in terms of public health and also other some diagnosis, the vaccine, and then the treatment. But at least based on this genetic maker, what you can actually just tell is that maybe the vaccine that we are actually using right now still be very effective. And especially the person who had already got infected by the Omicron will have a very strong neutralizing antibody against the Delta Crohn. And then for others, for example, like some transmissibility and then the severity, well, we actually have to wait for the further study, the results actually just come out.
I see, but for the time being, we do not have to panic too much then.
No, not at all.
On the local academic arena, Professor Kwak, under new COVID-19 guidelines, students, regardless of their vaccination status, can attend school even if they're residing with a COVID-19 patient. Having said that, what precautions do you recommend?
Well, obviously, the only method that we have as a prevention tool is really still the vaccination. So I strongly suggest those teenagers and schoolgoers who haven't been vaccinated yet to receive vaccines, but also to those people who have been completely vaccinated and still hasn't gotten their boosters. I believe certain age groups of teenagers are now allowed to receive boosters, so they should go ahead and receive their boosters because it clinically clearly benefits them from going into the severe courses of COVID-19. But also, secondly, I think it's keeping the common sense. Even before the pandemic, when a child was sick, we had them stay home for 3 to 5 days before actually going back there. If you were to have, let's say, a sick child at home, the parents still stayed careful not to really transmit to others when they go to workplaces and whatnot. I think that should still be kept in regards to going to schools, even with COVID-19. So people obviously having family members at home having COVID-19 should still refrain from going to school for at least a couple of days to 3 days, possibly because they would still carry higher chances of transmitting to others, even if the government is not mandating. So keeping the common sense, keeping hygiene, but also staying home for a couple or 3 days if they feel sick, or if it is sure that a family member is sick, then they should refrain from actually being possible of being contagious to other people.
Right, and as you correctly mentioned, of course, and it was also shared by my colleague Song, booster shots for those aged 12 to 17 have started on this Monday. Dr. Kim, also, well, come next Monday, that is, fully vaccinated individuals arriving into the country will be exempt from quarantine. What are your thoughts on the wisdom of this particular exemption, given our current COVID-19 situation?
Well, my personal thought is that if the number of just COVID-19 infection in Korea is very small, I think the quarantine in the airport and some border control is very important, because somehow we need to just very tightly control the number of just total infection, and also just preventing the some emergence of just the variants in our country. But the current situation now, we are actually experiencing more than 300,000 cases of COVID-19 in Korea. And then maybe my thought is that maybe just government has now decided maybe just following some domestic just guideline, maybe just enough, instead of just enforcing the very tight the border control as well that we actually did in the previously.
Right, I see. And Professor Kwak, our current COVID-19 restrictions with regard to social gatherings and business hours are poised to end this coming Sunday. What should be our new strategy moving forward, do you think?
Right, as many of the medical experts on not just this program, but many different types of report and media sources have emphasized the peak of the number of patients who are going through severely, and also the death rates is yet to come. If we go through the peak of the confirmation cases possibly this week or next week, the peak in the severity rate and also death rate will come possibly a couple of weeks afterwards. And already we're seeing almost very steeply filling up in the ICU bed units, which is quite worrying to me. We have already exceeded 1,100. As I mentioned before, we barely had 800 to 1,000 of bed units before. I don't know how well we have come up with 1,000 more currently. It is bound to jump up in about 2 to 3 or 3 to 4 possible coming weeks. Even if it means temporarily, we need to heavily focus how we are going to manage the upcoming severe patients. Even if it means temporarily, we need to start designated certain medical sectors and hospitals to solely be designated for treating COVID-19 patients in their moderate to severe cases. We would definitely most likely lack the capacity in the coming weeks. So what would that mean for next month or maybe a little more? We need to recruit more medical personnel. We need to recruit more physical spaces to really be able to care for these severe patients. Hopefully from that point on, after it has reached the peak of severe cases and death rates, we would be able to start letting loose of the condition again. But it is clearly foreseen by everyone in the medical sector that we are going into that dire peak in the severe cases and death rates. So we need to prepare ourselves for that at this moment.
Right, preparation is key then. All right, Professor Kwak, as always, thank you very much for your thoughts.
Thank you.
Dr. Kim, thank you very much for your thoughts as well.